Hello, everyone, and welcome to today's webinar in collaboration with Commonly Well, titled COVID Clarity, How the Pandemic Confirmed the Importance of Recovery Capital. My name is Meredith, and I'm the Marketing Program Manager here at Sigmund Software. I'm joined by my colleague, Evan Corey, our Content Specialist, and our speaker, David Whitesock. A few housekeeping items. We are planning to have a Q&A, so please feel free to submit your questions via the chat box. We will also be sending out more information via email following our webinar, so please keep an eye out. Our objectives today are to define recovery capital and explain its connection to the COVID-19 pandemic, and also to describe how a recovery capital strategy can expand the reach of care and support for those affected by addiction generally, and especially post-COVID. Sigmund Software is an EHR company that has served mental health and addiction treatment organizations since 2004. After working closely with many diverse behavioral health communities over the last 17 years, Sigmund understands and appreciates the intersection of mental health and substance abuse. Recovery Capital incorporates that intersectionality within a dynamic statistical framework, two elements that have always driven Sigmund's software innovation. Recovery Capital incorporates that intersectionality, Recovery Capital incorporates that, Commonly Well is a new technology and behavioral design company. Commonly Well's founder, David Whitesock, invented the Recovery Capital Index while working as Chief Innovation Officer for a peer coaching organization. The tool went through years of testing and was eventually validated with findings peer-reviewed and published. The RCI measures 22 indicators of recovery capital, general well-being, and a person's observed recovery from addiction. David's unique view of addiction recovery comes from his personal experience overcoming addiction and his near decade-long work seeking the best approaches for measuring all facets of recovery and designing new approaches for care. Before I turn things over to David, we have a poll that we're going to share. What you're looking at is someone's recovery capital over the past year. And what we'd like you to know, we'd like to ask you is what that dip in April means to you. What do you think it means? So please answer now. Oh, interesting. Okay, I think we've got all our answers. So David, I'm going to turn the floor over to you.
Meredith, and really grateful to be in this relationship and partnership with Sigmund Software, and in particular talking about recovery capital. Thank you for your responses on that question and on this graph of recovery capital. We're going to come back to this towards the end of our session here. But where we'd like to start is first define recovery capital. Now we're going to put this into context of a pretty incredible year that we all have experienced, that a lot of us have experienced around the globe. And when we look at recovery capital, it is, as the definition is here, it's those things that are inside and outside of us, where we are socially, environmentally, behaviorally, that helps an individual sustain their wellness, sustain their recovery. But one way to really think about recovery capital is as an umbrella term for recovery generally, but also as a subset for general well-being or quality of life. We're just looking at it through a lens of addiction or substance use disorder, and in particular, recovery from that condition. So as you can imagine, if I've experienced addiction in my life, looking at employment and housing and social networks and purpose and those sorts of things take on a slightly different view than maybe somebody who hadn't experienced that, but might have a different experience in their life. But that doesn't mean that employment and housing and social connections, and purpose, and all of those things, those all matter to everybody. We're just going to look at this as a particular view and the intensity that it might have for individuals who've experienced drug and alcohol addiction. Recovery capital as a concept, just like other quality of life measures or social determinants measures, has domains, has dimensions that it can be broken down into. And since recovery capital was first developed or coined back in 1998, 1999 by William Cloud and Robert Granfield, they started on the left here with the idea of social capital. And we'll talk a little bit more about that history here in just a moment. But when we look at these indicators, these very specific areas like nutrition and a healthy lifestyle and sense of community, we can put those into these buckets or these domains of social capital, cultural capital, and personal capital. And what that helps us be able to do is to track and measure and drill into each of those particular areas. And to measure this, we're doing it in a way that requires us to ask individuals about their observation, their affect, their evaluation of these particular areas in their life. We'll talk a little bit more about that subjective element here in just a moment. But how do we tie this into COVID, and why is the intersection and the relationship between COVID-19 and recovery capital really important? Well, I think as many of us have experienced, and as we are reading now in healthcare journals and in healthcare reporting and in medical journals and at medical schools like at Harvard, what we're starting to see is how when we pulled back during the COVID year of 2020 and into 2021 with less physical connection, less social connection, isolation increased. Just heard a story this morning on NPR about a rising increase in use of alcohol amongst female populations, and that more women are showing up. I think it was a 38% increase of women are showing up with symptoms of cirrhosis of the liver. These things are happening over the course of the year. That's actually been happening much longer. But now we're increasing, as you can see, with the average share of adults reporting symptoms of anxiety or depressive disorder going up fourfold from just a year prior. So individuals that aren't necessarily affected by addiction, aren't experiencing addiction, are starting to experience the underlying symptoms like anxiety and depression and stress that tend to lead into or progress what becomes substance use disorder and addiction long term. So we're rolling back the chain and we're seeing all of these underlying elements start to be much more heightened. And to get a sense of the people that we might serve, if you are a practitioner, a medical doctor, or a counselor, or a therapist, or somebody who works in addiction treatment or behavioral health care, individuals that are coming into your programs, this is the previous tale. These are the lagging elements that led to individuals coming in. And this is becoming more and more heightened across a much wider population set where we happen to be. And so if we can understand recovery capital, if we can understand the longer wraparound of what's out there, we can be better attuned to how we intervene with folks and address their needs so that they can actually sustain long-term recovery. Again, some of the data that's coming out relative to the COVID-19 pandemic is this rise of symptoms around depression. And you can see before the pandemic, as it was reported, versus afterward, it's increased across the board from mild all the way up to severe. And those are CDC numbers, by the way. So William Cloud, he was the individual. We'll just kind of go back in history just a bit, provide some context around recovery capital itself. William Cloud was a social worker to start, and then he became a professor of social work at the University of Denver. And in the late 90s, he spent a lot of his work looking at social capital, but then started to understand and wanted to ask a particular question of why some individuals whom he was engaging with as a social worker who were dealing with addiction or substance use disorder. Why is it that where some individuals would go into treatment multiple times and really never get well, but some people who had the same symptoms, the same intensity of issues or challenges of the condition, why those people may never go to treatment but get well? What was the difference in these two types of people? He called that natural recovery versus clinical based recovery. He wanted to know what was the difference. And where he started was in the area of social capital. But what they came to start to question was, well, there had to be more than just the friends or the family network that we had for people to sustain recovery. It was job. It was cultural relevance. It was a lot of these other things, this other web of elements that people needed. And so as he was sitting around having hamburgers one night in his backyard with Robert Granfield in Denver, they came up with the term recovery capital. So who am I? Why do I care about recovery capital? And maybe what was my intersection or journey in some of this? And I won't spend a whole lot of time here, but I do want to just give you a quick story. This was me in the fall of 2005 after being convicted of a third offense, felony DUI, in a small little dusty town in central South Dakota. This was at the end of 12 long years of struggling with addiction and depression and anxiety. It was actually my fifth DUI. In the course of those 12 years, I had gone to college. I had maintained a profession for a while in radio as a radio broadcaster. But addiction really kind of took over, and depression really took over my life for quite a while. And I ended up into the criminal justice system. In the sentencing for this particular instance in September of 2005, the judge was looking at my record, at my pre-sentence investigation, and she was looking at my life. And she couldn't understand, and she talked about this in open court. What she couldn't understand was, how could somebody like me, with all of those things that I had a family in the courtroom who supported me, who had supported me along the way for a long time. I had a college education, not complete, but college education. I had a long-standing profession in journalism and broadcasting. I had access to financial resources. I had a lot of the stuff that should have protected me against these things. And she just couldn't understand, how was it? Why was it? What was missing? What she was describing at the time was recovery capital. I didn't know that. It would take me leaving jail, going into a sober home in Sioux Falls, South Dakota, eventually being navigated to going back to college. When I got back to college, I took an elective in constitutional law. That professor was a public defender. She heard my story. I was planning to go back into broadcasting, and she said, David, that would be a waste of your time and talent and your experience. You need to become a lawyer. I thought she was crazy, but I followed her lead. She knew something I didn't, and eventually I would get into law school. After law school, I passed the bar exam. And for me, somebody who with my past would have to go through a long process of character and fitness. I actually had to prove up my recovery capital. I didn't really know what that was, but as I was preparing for my Board of Bar Examiner hearing and the 14 elements to prove my good moral character, I had just started working for an organization that did peer coaching. And we were told that we needed to move from anecdotes, telling recovery stories, a lot like the story that I just told you and the power of that. What we had to do was change that and get data. And that fell to me. One of our co-founders said, David, you've got 30 days. Figure out how to measure addiction recovery. And that began going down the rabbit hole of recovery capital. But I was also building up my case with the Board of Bar Examiners. I made that case. It took a year, and eventually I was able to go back to that same courtroom, same judge, and instead of wearing orange, was able to be sworn in as a lawyer in the state of South Dakota. And so that's the kind of a practical understanding of a lot of these elements over the course of the 8 years from being in that orange jumpsuit to being in a business suit, not wearing any orange whatsoever, reviewing all of the things that helped me get to that point, like education, like good work, like solid connections, mentorship, figuring out what my beliefs and my values are. All of those things came together to make something like that happen. So as we think about recovery capital, as we start to think about what COVID has done to the fabric of our society and the connections and the way that we interact, addiction is becoming this bubbling problem. And it might not necessarily show up as addiction. It's going to show up, as we saw in some of the research and the reporting, as anxiety, as stress, as excess alcohol use, as depression, as challenges around housing, challenges around transportation, a lot of these different things. And so these are starting to fuel up and bubble up, and we have to understand those things. And we may need to, as practitioners in behavioral health or healthcare or addiction treatment, we may need to change our strategy a bit and widen how we intervene with those clinical expertise and those clinical tools to engage folks. So now, what does this strategy start to look like? What does recovery capital look like when we put it into action? Well, the first thing we have to understand is, in order to gain insight into things that are like an individual's well-being or their emotional stress or their social connections or their beliefs or purpose or values, those things, we actually have to ask people those questions. And we can structure that in a way that we can take those subjective observations of one's life and we can structure it so that the responses that we get are limited in their scope in terms that they're discrete. And that increases the power and validity and reliability of those responses. In the economic and psychology world, we call that experienced utility. That's the sort of the academic term. We can take those experiences and we can use that to start to really understand. And I know what you're thinking. You're thinking, well, individuals in early recovery, sometimes it could be a challenge of getting really true responses from folks. They might embellish or not want us to know anything that might be going on because of shame or fear. All of that is relevant. But in our experience, as we are working with people and building strongly dignified relationships and trust builds, over time, those responses get more strong. They get stronger. And we can look at that as it's coming together. And there's a lot of power in one individual, maybe not necessarily having the communication skills to tell anecdotally or tell deeply all of those things in their life, but we can now structure into kind of a response framework. Here's what is going on in a person's life. We can ask the right questions and get a very nice picture of their life. And so that subjective experience becomes really powerful. And we can look at that in a lot of different ways. We can start at the micro level as an individual, and we can take that input and we can start to inform their care, build treatment plans that are a little bit more tailored to those other experiences, those outer influences that we know are going to keep influencing. And if we don't do something about it, no matter what I do clinically, if I don't fix the one thing that's out there, like an employment or housing or some other thing, if I don't fix that, whatever clinical intervention I throw at, it's not going to work. It's just not going to happen. I've got to fix that one basic need first. But you'll see that, you'll understand that. And maybe that means you can go out into the community as an organization, because now you might not have just one person experiencing that. You've got hundreds of people experiencing the same thing. Now you get to be a strong stakeholder in that community to go out and say, this is exactly what our population is struggling with. So to policymakers, to advocates, to your donors, to others, you can start to change the narrative. And now you've got data to back that up. And it's not just survey data. No, this is the real story of the people that you're working with. You could pull one out, have that person actually tell their story, have the data to back it up. You can bring that to the community. You can map it as a whole and show where there are gaps in the community, where there are really strong, well-knitted social fabrics in the community. You now get to be much more engaged as an organization in your local community to bring change, to start to solve this addiction crisis that we have. Now, how do we actually measure this, and how do we get to understand this information? Well, the tool that I developed is called the Recovery Capital Index. And what you're going to see in a couple of moments is data, recovery capital data, and it comes from this particular instrument. We scientifically validated the instrument, and what that means is it measures what we say it measures. So if you go from currently struggling to in recovery, that subjective or that affect understanding, your score, the quantification, but also the qualified responses will improve, and they should improve. So we can predict that is the case. It's 68. It's a 68 item survey. Scores from 1 to 100. It's broken down into those 3 domains, 9 components, and 22 indicators. And so we can use that information. It's not an instrument that is a pre-post instrument, nor is it to be used for diagnostic purposes. So when you look at this data, know that this is coming from individuals who are measuring the barometer of their own recovery well-being over time. That's changing all the time. We'll start with this view here. So employment is obviously really important and can have a major impact. It can be a protective factor. It can be a predictive factor for individuals. What I want to kind of show here is over on one side, these individuals who are identifying being full-time employed. Their recovery capital is really well knitted together. So on the bottom, this red bullet is personal capital. The orange is cultural capital. You can kind of see that cultural capital is more across the top. What we're seeing is those are folks that typically people are finding more cultural relevancy, and that's a bit more in tune than some of the basic needs of this population, which are more lacking in some places. What I really want to point out is here's a group of full-time with an average recovery capital score around 65. But if we go over to individuals that are part-time, they actually have a higher overall recovery capital score. Why is that? Well, a lot of this data came from 2020. Our running suspicion is that this is a group with, although there was uncertainty, being part-time employed reduced the level of uncertainty, and the recovery capital just happened to be a little bit higher in this group, who might have a bit more fear of what might be to come, or what they might be actually experiencing in that moment. You see folks that are retired, they have a lower recovery capital, but it's more tightly knit. Those that are temporarily unemployed, a lot of variance. This is where you can see that there are some significant challenges with that particular population. One of the questions, or one of the items in the Recovery Capital Survey, looks at isolation and loneliness. So if you read any story or read any report on isolation and loneliness, which we do see as increasing, it comes from this question. If your friends or family or social networks don't know that you're struggling, maybe because you've removed yourself or communication has disrupted, that's where this comes from. And what we see in this particular population is that 83%, so if you count up strongly disagree, and uncertain, 83% of this particular population says that they don't think that there would be somebody there who would know when things are wrong. That is a crisis inside a crisis inside of a crisis, or an epidemic inside of an epidemic inside of an epidemic. Now, the stakeholders who have this information, they now have a new way to view the population that they are serving. And they can start to think, okay, we need to reallocate funds, and we need to work on different partnerships or collaborations to fix this. Because if we don't fix this, this is their leading indicator now. If they don't change this, systems are going to get overturned or overwrought, overcapacity, and it's going to be a challenge to help people in a significant way. So let's go back to this chart of recovery capital over the course of the year and look at your responses. The question we asked was, this is somebody's recovery capital score over the last year. This is December of 2019, actually, to December of 2020. We all know what happened during that time. What do you think caused the big dip right here in March, April-ish area. So it looks like we've got 50% of you said a recurrence of symptoms. So in other words, a relapse. We had a response of a death in the family, and then a couple that said maybe loss of employment. Well, what I will tell you is this was not necessarily a relapse or a reuse of drugs and alcohol. It was a recurrence of symptoms. There was a change in employment, and there wasn't necessarily a death in the family, but there was death all around. This actually is my recovery capital. I told you that my journey into recovery and wellness began in 2005. I haven't used alcohol or drugs since July of 2005, but anxiety and depression and stress are constantly there, always working with it. I knew my world was going to change in February and March. The job that I was in was dramatically changing, and I moved. And so my job ended. I started a new company, a new business, and a lot of things were in flux. I moved from Denver, Colorado to Northern New York. A lot of life changed, but this right here, this is my resiliency. This is what resiliency looks like in terms of recovery capital. Not perfect, but we had this and we rebounded. There's another little dip. This was actually a depressive episode. There was some depression in here, but this was a very specific episode. But this is resilience. So this is what recovery capital looks like when we really get down to it. Now, if you're tracking this and you're engaging with somebody, and I was working with people and working with myself, I knew this dip was happening. I'm now in the moment. I'm working with it. I'm preparing myself. I'm in that. If I'm working with a coach or a therapist or I have a doctor, this now becomes my ongoing barometer. It's almost like if I'm wearing a Fitbit and I can see I'm not walking as much, and my steps are going down. How do we engage in that as it's happening so that we can change it, improve our steps, get our health back, get our life back into a place of normality? That's what that looks like. So pause right there. I know we've got Evan waiting in the wings. He may have some questions that you may have provided while I was talking. So I'm going to turn it over to Evan to bring up the questions and moderate some of these answers. Thank you.
Yeah, well, David, thank you so much for the wonderful and insightful presentation. It appears that it was as thought-provoking as I expected it to be, because we do have a few questions. So let's just dive in. Looks like we have about 5-10 minutes for questions. First question is, what motivated you to try Recovery Capital for the first time? Was there a certain moment that you chose the Recovery Capital system?
It's a good question. Obviously, from my own experience, I had to understand the underlying factors that were either going to be the change in my own personal life or not. But when I was working for the organization I was previously at doing peer coaching, we had a very specific problem. One of our healthcare partners needed data. And so the only way we were tracking, are you satisfied with our service and those sorts of things, but that's not actual change data. So we had to figure out, how do you do that? And the only way that we could get there, this was 2012 and 2013, was Recovery Capital. I read everything and engaged with William White and David Bast and Alexandra Laudet and all the people that have been working in this for a while. And we just knew that we had to do something there. And we looked at the other survey tools or the scales that were out there, but we just had to go a little bit deeper to really get to the complexity that exists. We had to peel back the layers of the onion and be able to re-put those layers back.
Absolutely. And you mentioned earlier in your presentation how your co-founder gave you 30 days to find a Recovery Capital or an addiction system for the RCI, or what would become the RCI. And we actually have another question that was asking about, did you see any other approaches, or did you look into any other approaches, systems for addiction, for tracking addiction in that time? And did they fall short in a way that Recovery Capital didn't?
Yeah, obviously the first one that we looked at was William White's Recovery Capital Scale. It's 50 items or 50 questions. There's a shorter version of that called the BARC 10. We looked at that pretty deeply. We worked with researchers at Baylor University, a neuroscientist from NIH. We also had some professional evaluators that we worked in the field. What we found was those particular questions didn't have the long-standing history of validation that other general well-being surveys do. So in the world of measuring well-being and happiness, there are instruments that have been out there for decades and have been used, and there's mountains of data. We were able to go and use those questions because they were in the public domain. There were some areas that we had to reinvent and add new questions. And that's where we could turn to the recovery capital scale and other places. But also what was missing was those questions didn't fit into the framework which was being presented, which was personal capital, social capital, and cultural capital. So we had to do that work too. We had to figure out, okay, if we're going to take these other questions that exist, how do we actually identify them in that framework? And so that's kind of what was missing. And that's where we had to get to say, maybe we have to take a different approach to this and make it a bit more structured.
Absolutely. Great. This third question is actually one that I came prepared with because at Sigmund, we're always thinking about the behavioral health aspect, mental health, treatment, how we can, empower our clients to leverage different approaches through our technology. So how are there any other traditional behavioral health treatment approaches that mesh nicely with the recovery capital? Can that be used as a one tool along with other approaches to give that comprehensive care that people in recovery do need?
That's a really good question, and I might reframe your question just a little bit to say, as a clinician, what clinical interventions or what clinical approaches am I using that mesh well with this? And there's a couple that come to mind. One of them very clinical, and that's cognitive behavioral therapy. So when we think about individuals working through thoughts, actions, and behaviors, when you start to see those responses in those particular questions, you can then ask, if the question was, how's my general well-being today? How's my general health today? I'm going to respond to that statement, and I'm going to have certain thoughts around that, and I might have certain actions or behaviors against that response. But as a therapist, I can now dive deeper into that using CBT approaches. The other, on a less clinical end, maybe with, say, peer support, motivational interviewing. So as you're reviewing these items and you're reviewing the questions and the responses, you can use active listening and motivational interviewing techniques to pull a little bit more deeper from the individual to sort of get to the core and the root to then decide, okay, now what do we do next? Which motivational interviewing sort of is that leading way to get Evan to say, what you want to do, not an option that I devise and lay into you.
Great. And we actually just had another question come in from Peter. It's actually a great question. And David, I think you're a perfect person to answer it. But the question is, how has RCI been used in DUI, or has the RCI been used in DUI or other drug criminal cases to help defendants to support their case, perhaps as a part of pre-sentencing reports?
A great question, Peter. In fact, so Face It Together is the nonprofit organization that I was with before. And we had one coach in particular who was on a drug court task force. And she was actually on that court. And she was always in the court every week. And so the judge for a long time was assigning individuals, participants, to Alcoholics Anonymous and mentors in clinical therapy. But eventually over time, because there were still some issues or challenges and people saying, I don't want to go to AA. Finally, the judge threw her hands up and said, okay, go to Terry. And what happened is Terry, our coach, because the organization was using the RCI, when it was time to write letters of support, we would actually provide their recovery capital history. And we could put it in context, but also give the raw data. And so that occurred at a lot of different stages in the criminal justice process. Sometimes it was pre-sentencing. Sometimes it was a sentence modification. Sometimes it was individuals who were probably 4 or 5 years removed looking for pardons or commutations. Yeah, so it's been applied in a lot of different ways, and
That's
in
great.
particular, one and just sorry, I wanted to mention, and in one particular way, in collaborating specifically with probation and parole officers, having that in a very consenting way, having that conversation with those people.
That's great to hear because it just goes to show how that raw data really almost breeds compassion in how you consider the patients, but also gives you that wider context of everything that's going on. So that's great to hear. Thank you, Peter, for that awesome question. And looks like we have a few minutes left for a few more questions. So if any of the attendees have any more questions, please feel free to put them in the chat right now. I will move on to the next question, which is a question I actually like a lot. Is there anything you're most excited about in the recovery capital world, maybe in the next year and then 5 years in the future? Anything that you're really excited to see develop?
I think for the first time in a long time, although we're starting to trend this way, we're going to move the conversation around addiction or substance use disorder away from substances. And every decade, there's always a substance that sort of occupies our attention. Currently, it's opioids. Previously, it was methamphetamines, and then it was heroin and cocaine. And underneath all of that is alcohol. But it's never really the drug that's the problem. It's the environmental, the behavioral, the economic, the social fabric elements that carry these conditions from decade to decade. So I think we're going to start to have a much deeper relationship to the underlying and upstream factors that cause, I'm going to use that word carefully, but that actually cause addiction. And we're going to move beyond it. And we're going to start to find community-based solutions or policy solutions that will protect against addiction. I think that's going to be really exciting to see how that comes together.
Absolutely. And that makes me recall one of my favorite phrases of yours where you say, we'll start treating addiction, or we'll start curing addiction when we stop trying to treat addiction. And forgive me if I'm getting it a little bit wrong, but it's resonates with me and really connects to that answer as well. And we have another follow-up from Peter. Thank you, Peter, so much. And he says it seems like the RCI could be used to help professionals regain a lost license, like on a medical board or of examiners. Anything there?
Yeah, in particular, again, with the organization that I previously worked with, we had a strong relationship with the state's health professional assistance program. And there were a number of nurses and doctors and others who were required to engage in particular programs, and it was in the agreement. And so that information of the RCI data was used in helping maintain that case.
Awesome. All right. Looks like we have time for one more. Oh, all right. Thank you, Scott. Scott just popped up at the nick of time for our final question. He asks, could there be a recovery capital index developed for communities? Can communities become healthier environments and means developed to measure community progress?
I love that question. The answer is yes. So because most of the questions come from general well-being surveys, and the way that we have written the statements or questions in the RCI kind of hedges on that. It'll say recovery and or well-being or recovery and or wellness practices. You can use this survey with people that are not in recovery, right? It's the same general type of questions. And so, yes, you could put this survey out into the general population of a city, a county, or a state, map those responses and run that in the background. So as policymakers and community organizers and other folks are trying to change community health, they could have that barometer in the background. And I'll just say, one of the influencers and a lot of the people that I worked with over the years that helped inform the construct of the RCI are the people who work with the Social Progress Index, which is kind of a newer emerging global indexing scale. So the answer to that is yes, and that's really exciting.
Awesome. Well, thank you everyone for your great questions. Before I throw it back to Meredith for some closing remarks, I just want to let everyone know that this webinar actually isn't the first collaboration about recovery capital that Sigmund Software and Commonly Well has engaged in. It actually started earlier this month with a blog series called Recovery Capital, series on sustainable recovery. And it's an effort to continue and push that conversation forward and providing a platform of education for recovery capital because we really see the benefits and the merits of it. So the next installment of that series will be actually the transcription of this Q&A, which the questions that David answered here and a few ones that we didn't get as well. So we'd love to see you over on our blog and continue that conversation. David and I will continue to put our heads together and put out some insightful content. So thanks again, David, and I will throw it over to Meredith to close things out.
Thanks, Evan. Thanks, David, for an engaging talk today. As we bring our webinar to a close, we once again thank you for joining us and hope that you have a clearer understanding of the intersection of COVID-19 and recovery capital. Please stay tuned for some additional information coming to your inbox. Thank you for joining us and have a great day. Bye.